Before we get started, just a quick word from World Extreme Medicine. If you work in pre-hospital, remote, expedition, humanitarian or high-risk environments, World Extreme Medicine exists for one reason: to help you deliver safe, effective care where resources are limited, decisions matter, and help is a long way off. From expedition and wilderness medicine to hostile environments, dive medicine, leadership, and human performance under pressure, World Extreme Medicine bring together clinicians and operators with real-world experience in some of the most challenging settings on the planet. Their courses, webinars, and global faculty are built around practical decision-making, not just theory, to focus really on what actually works when things go wrong, far from definitive care. To find out more and explore upcoming courses and indeed educational content, visit worldextrememedicine.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're diving into one of the most common and challenging injuries we see in pre-hospital care, that of neck of femur fractures. So with an aging population, these injuries place a huge burden both on the patient and, true to say, on the healthcare system as well. But at the same time, the approach to management of neck of femur fractures is evolving rapidly. So we're going to be exploring in this conversation the contemporary and future directions in care, from pain management innovations like fascia iliaca blocks to specialist triage pathways, and also new bundles of care designed to improve outcomes. We're also going to look at the contrasting priorities between elderly patients and younger patients, where joint preservation becomes critical, yet outcomes can historically remain poor. So joining me to unpack all of this is Emma Moore. Emma is a senior lecturer in Paramedic Science at CQUniversity in Australia. Emma brings a wealth of expertise and experience in paramedic education and pre-hospital care practice, and we're excited to have her here today. Emma, welcome to the podcast.
Thank you for having me. Excited to be here.
It's great to have you on, actually. I wondered if we could just start, Emma, just by getting you to really speak to an overview, really, of the current landscape of neck of femur fractures and indeed, well, neck of femur fracture management, really. What are the biggest challenges we face at the moment?
Yeah, absolutely. I think the first thing we need to say about neck of femur fractures is that they're not just a fall or a minor fracture. So these can be really life-changing injuries. They have the potential to strip away a patient's independence, their mobility, confidence, and they really happen to our most vulnerable cohort. So we're talking about our older adults, often in their 80s, mid to late 80s. They can be frail. They've got multiple comorbidities, predominantly women. So straight out the gate, we're already dealing with a high-risk group, plus. So pre-hospitally, I think the biggest challenge is just the sheer complexity around this cohort. So they don't just have a fracture. Like I said before, they could have frailty, comorbidities. We're talking about cognitive impairment, communication barriers, and then we've got the fracture itself, which at times doesn't present in the textbook way. So sometimes we can have this fracture that doesn't have the obvious shortening and rotation. So we've got this sometimes subtle injury with a not so subtle patient, often talking about a cramped lounge room or a bathroom. They may be lying down all night because they didn't want to wake us up or bother us at night time. They're distressed, they're in pain, they're confused, they can't communicate. And that's a lot to navigate before we even sort of talk about the injury itself. And then as you touched on at the beginning, we've got pain relief too, which I think is another major challenge in the pre-hospital setting. And it's complicated before we even open up the drug kit. We're talking about patients with a low physiological reserve, potential sensitivities to medications. They're on multiple levels of medications, and our analgesic options vary depending on our clinician's training, scope, service capability, which leads to inconsistency of care. And then we've got to think about long transport times, rural settings, ED ramping, and you've just got this major complexity again. And this patient that can be in pain for longer than what we would like to hope for.
It's never a simple picture, is it? To your point
No.
around multiple comorbidities, but also you're right as well. The often the area in which elderly patients fall, or indeed the majority of this patient population falls, it's difficult, protracted extrication, but also as you were saying, pain management and the sequelae of maybe poor pain management over time. And we'll dig into all that actually, Emma, because I
Yes.
think it is such a challenging cohort. But could I get you to really just maybe unpack for us, the burden of neck of femur fractures is rising with an aging population. From your perspective, Emma, how are we in pre-hospital care adapting to meet this demand?
Yeah, so I sort of can talk from the Australian context. I know it's a little bit different to some of your listeners, but I think in Australia, the in-hospital side of neck and femur care has come a long way. So we've got a register called the Australian New Zealand Hip Fracture Database, and they've really driven improvements with fast-track pathways, orthogeriatric input, structured models, which is really good. And you can see these outcomes in their annual reports. But when I chat to paramedics as part of my research, I think the pre-hospital picture looks very different. So I'm getting a lot about geriatric patients, so not just NOFs, but older adults in general, keep coming up as an area of uncertainty for paramedics. So there's this real apprehension around assessment communication, and that uncertainty becomes harder when then you have to layer this potential NOF on the top. There is some good news. So the ambulance service that I used to work for has a 4 co-responder program, which is sort of is addressing this older population burden. So it's a paramedic timed with an allied health clinician. So they'll go out and assess people who have had a fall. It's just their simple falls and, have a look and see if they can get them up and get them to a GP. And that sort of stops that transport to hospital, but that's not related to NOF. So if there's any major injuries, an acute care would come. And interesting, more specific to NOFs, there is this really nuanced innovation happening in Queensland. So there's this group in Brisbane, which is attached to a hospital and the ambulance comm centre. And if there is a NOF, they actually will drive out to the patient's residence and deliver a block, which is super duper exciting and sort of new. And it's showing some really positive results. So hopefully that might develop out a bit more as it progresses, which is exciting. So yes, it's there, but it's not great just yet.
Let's talk about that actually, because I think bundles of care really have progressed over time. And actually, the emphasis on providing a package or bundle of care within the pre-hospital environment, Emma, to your thoughts, how have bundles of care within neck of femur fractures progressed within time, and how do you perceive them to sort of influence and improve outcome?
Okay. So at the moment, and this might shock and surprise some people, but in Australia, we actually don't have a dedicated pre-hospital care bundle for neck and femur fractures, or even a guideline for our paramedics targeted to this injury. And I guess that gap really shows in my research. I'm seeing huge uncertainty and variation around assessment, pain management, movement, and decision making. So I think a bundle of care would make a massive difference just by giving everyone the same foundation to work for. So if I could, we don't have one, but if I could design one, I think it would come down to 4 main areas. First would be early recognition. So working on that assessment and that communication skills with the patients to really have that high level of suspicion. Second would be early structured pain management, looking at both pharmacological and non-pharmacological, like with this clear escalation pathway. So we can go from our simple oral analgesics all the way up to nerve blocks if that's what our service can do, which is good. Third, I think it's just looking for minimal careful movement. So treating the patient with respect and not sort of roughhousing them out of there. Sometimes, yes, we'll have to if they're sort of in that awful spot, but just trying to slow down and look after the movement there a little bit. And then finally, timely transport to the right place. So not just going to the nearest close hospital, getting to them to a surgical orthopedic specialist centre where we can. I know it's not possible all the time, just to help avoid those delays.
I think the bundle is fantastic because I think, as you were saying, it's a number of things, and that's immediate actions. So it's recognition, it's pain management, it's looking at perfusion, and indeed the on-scene bundle of care. And it's also something which sets me up nicely for this next question, really, which is around streaming. A pathway whereby they do get specialist care. They get prompt surgical reviews, prompt X-ray, a specific pathway of rehabilitation. So, could I get you to speak to that, really? Just how you see these pathways changing, and or maybe emerging, but even just that recognition that this is a good thing to do between pre-hospital teams and in hospital teams.
Yeah, I think it's really important. I've just done some focus groups, and a participant summed it up beautifully. That they said that all the data in our research starts in the ED, but the patient doesn't just float into the ED. They've got to get there somehow. And I guess that really stuck with me, and that's sort of streamlining what's done pre-hospitally can flow on as well. Now in Australia, we don't have any. They all go through the emergency department. Um, but how good would it be to sort of get this fast track recognition out in the pre-hospital setting so that we can get the hospital ready, we can get imaging, they can go straight through to imaging, get that done, hopefully optimize for surgery, get them nice early surgery, have that all done instead of getting them to the emergency department where they get ramped and are stuck on an uncomfortable ambulance stretcher for hours on end. If we could get that activation, but it will come with, you've got to have the assessment. And so the paramedics need the confidence to assess and go, yes, I've got a pretty good suspicion that there's a neck of femur here. So let's activate pathways. I think it'd be improve outcomes significantly.
Yeah, indeed. No, indeed. So let's talk about pain management. The role of analgesia is critical. With the adage of now paramedics or critical care paramedics carrying ultrasound devices, could you talk us through the role of fascia iliaca blocks in the pre-hospital setting? Whereas before it might have been purely conceptual, it seems more tenable and more reasonable now to look at the role of blocks. Could I get you to really just maybe unpack them and where you see that heading?
Yeah, so blocks are a really exciting area for pain management in the pre-hospital setting now, aren't they? There's growing bodies of research that's showing just how effective they can be. The research is in the emergency department, but there is more coming out in the pre-hospital setting, which is great. It's consistently showing their ability to deliver rapid pain relief. We don't have fewer systemic side effects, so it's really good, particularly for this complex cohort. So definitely excited about blocks, and I think they have a real potential. But to balance it out, I think we need to have some practical realities around blocks as well in the pre-hospital setting. So they're an advanced skill. Not all clinicians will have the training or the confidence to perform this skill safely. So, we also got to think about training requirements, credentialing, and all those cost experience considerations as well. And if we think about who would be giving the blocks, it's usually our higher level clinicians. And typically, they're pretty busy doing the higher level jobs. So if we're pulling them off, I know it sounds awful, but a big injury like a cardiac arrest or something to give pain relief for a NOF, which is important, absolutely. But when we talk about that life criticality, there's that balance there that's going to be a little bit hard. So yes, I think they're good. I just don't think they're going to become a universal blanket for everyone. Just definitely part of the pain relief option if we can with targeted deployment. So maybe like that group that I was talking about in Queensland, where we have this specialist group that we can say, yep, can we come out and get some blocks? Might be a good option there.
Yeah, indeed. So, what's to your point, actually, Emma? If they aren't necessarily appropriate in every patient, or indeed, the resources aren't there, and indeed the specialist training and/or teams, could you talk us through some other strategies, pharmacological or non-pharmacological strategies, really that show promise within pre-hospital pain management for neck of femur fractures?
Yeah, I think that's a good question because blocks are sort of the sexy hot topic at the moment, but there's more to pain relief than those. And I guess when you think about a fracture, the first thing you probably think about is immobilization. And funnily enough, that's what sort of neck femur mobilization is what got me into this topic in the first place. So I always immobilized a neck of femur fracture. I was taught how to do it from my clinician. It was sort of handed down. Interesting, when I started digging a little bit deeper into it, I actually realized there's very little high quality evidence behind many of the immobilizations techniques that we're using for this particular injury, which was a little confronting. And it really highlights how much our practice, it is getting better, but was more tradition based rather than evidence based. So definitely looking at immobilization, but we just need to look into that a little bit more. Beyond that, I think there's heaps of other options that we've got non-pharmacological. So I think one of our most powerful tools, it's not going to sound fun, is the fundamentals, doing the fundamentals exceptionally well. So our minimal handling, positioning a patient in the way that they can tolerate, not what we assume they can tolerate, keeping them warm, avoiding unnecessary movement, communicating with them, explaining what's happening, giving them that sort of patient-centered response. It's not glamorous and it's not showy, but it all can help reduce pain, calm the patient, and stop that physiological stress. And then I guess if we're thinking pharmacologically, we're seeing more structured pain pathways, which is really good. So we're getting a little bit smarter with our use of oral analgesics and our opioids, talking about that multifaceted, multimodal pain relief, which is really good.
So just looking at younger patients, actually, Emma, because it's a different, well, there's a different lens with younger patients in a way. I guess joint preservation is one of the primary goals, but outcomes can remain poor with, in a way, high rates of avascular necrosis and or high non-union rates. Could I get you to speak to really how we as pre-op clinicians can frame their approach when there is a younger patient? I guess in a way, these care bundles and these pathways become all the more important to really avoid AVN and non-union rates.
Yeah, so I think when it comes to the younger patients with the NOF fractures, the whole mindset needs to change a little bit. These injuries are usually a result of a high energy mechanism, such as a car crash, our big falls, our serious traumas. And we really want to have joint preservation. So we want to keep their natural hip for them because they're younger and they need it for a longer time. Our major drivers for non-union and our avascular necrosis are our displacement and our delays to surgery. So for paramedics, getting them to the definitive care and that surgery is our key focus. So what I find fascinating is that early surgery matters for both the geriatric and the young cohort, but it's for completely different reasons. So in older adults, we're looking for early surgery to reduce the physiological load. So we want less pain, less delirium, fewer immobilization complications, get them up, get them functioning again. But for younger patients, we want early surgery to get that blood flow to that femoral head, to keep it viable and structured. So when we meet a younger patient, it should be a high stakes trauma case, give some good analgesia and get them to that surgery as soon as we can, look after that hip.
And do you see really real value in pre-sport teams being able to flag potential high risk patterns of injury, but such as displacements or indeed sort of in a way, complications that aid early surgical planning? Because to your point, I think if there is no articulation of potential complications, outcomes in a younger population, and therefore long-term disability and morbidity can increase.
Yeah, definitely. I think if paramedics can assess, we mentioned things like, posterior comminution and our Gardens classification, and they're good to know, but really hard to determine in the pre-hospital setting. You really need your imagery to sort of be confident that that's what you've got. So I think what is achievable and actually valuable in the pre-hospital setting is recognizing our risk patterns, like you mentioned. So looking at our high mechanism, our severe pain, our inability to weight bear, a leg that feels unstable with even minimal movement. If a paramedic can sort of flag this with the hospital and say, we've got a high injury mechanism, or, we've got likely displacement, there's shortening in rotation, I think that would help so we can flag high risk features will help with that streamlined system there rather than the classifications, if that makes sense.
Yeah, it does. It absolutely does, actually. So just pivoting slightly, Emma, and looking at education and skill training, could I get you to really speak to maybe what skills and training paramedics should be prioritizing to deliver the next generation of neck of femur fracture care?
Yeah, love this question. So this is what my research is about. And I really think we need to reduce the variability that currently exists in practice. So right now, management can look very different depending on who attends and their level of experience. And I think that inconsistency is really upsetting and it's just not fair on this cohort. So I would love to see first an improvement across the board in geriatric assessment skills. So understanding frailty, communicating with people who have impaired cognition or vision or hearing, I think that should be fundamental and how we communicate to our patients. I think we need to be more targeted and more clever and smarter with our pain management, not just let's give some analgesia and let's go, but this structured context pathways that we need to know how older bodies respond to drugs, look at multimodal options, stuff that will helpful while we're moving and then while they're at rest. So that sort of complexity there. And I'll harp on it again because it's boring, but I think it's important, is our non-technical skills. So having that calm communication, involve their family, be confident and, understanding that this is a significant injury for them. So be reassuring to them and acknowledge that it's a pretty big deal for this patient. They may not come home, so they may be frightened. So just helping with that. I think how we show up and how we deliver our communication really matters. So it's not just all about managing a fracture, let's get them some pain relief and get them. It's about managing that patient as well.
So we've spoken to this slightly, and we've done a lot on the podcast actually, Emma, around sort of the importance of rapid conveyance, but also uh, really, and yeah, I hate the term sort of scoop and run or stay and play because that's not really where principal care is at anymore. But there has been a real focus on scene optimization of these patients, and not just neck of femur fractures, just actually lots of different kind of pathologies, really optimizing. So you're not almost kicking the basics well down the road. You're optimizing on scene. Could I get you to really, in a way, just speak to that optimization, pain management, assessment, communication across the multidisciplinary team, and really, to your point, smoothing the pathway, really.
Yeah, I don't think it should be a choice of one or the other. I think it should be more focused about it, giving the right care at the right time for the patient. So, yep, absolutely. Unnecessary delays can cause harm, but so can rushing, rough handling, or leaving someone in pain because we're too focused on getting to the hospital. So, I think the sweet spot for patient and pre-hospital care is right in the middle. So, we should be delivering early, effective analgesia, doing our meaningful innovations that reduce pain and help to reduce that physiological stress. And then once we've got the patient packaged and calm, we're moving to rapid transport, going to the direct hospital that's going to look after them the most. So making the right decisions there. For me, on-scene care should be focused and deliberate. So we want to assess, we want to reassure, manage the pain, handle gently. And then once they're sorted, let's locked in, let's get rapidly moving to hospital, if that makes sense. So it sort of sits somewhere in the middle for me.
And so, just looking forward, a couple of questions as we come into land, Emma. One would be really around if I could get you to unpack any innovations or indeed um, technology or models of care that excite you the most, really, about the future of pre-hospital neck of femur fracture management.
Yeah. So one isn't in the future, ones that I hope will happen. And I'd really love to see better use of pre-hospital data. So right now, most of the quality indicators we rely on start the hospital door. But paramedics, we can gather lots of rich information. We can talk about frailty, we can talk about increases in delirium, pain patterns, and that. If we could integrate pre-hospital data into the hospital systems and research, like start getting research to come out of the emergency department into the pre-hospital, I really think we could get some answer to some big questions. So, does early analgesia change delirium risk? Does gentle handling influence pain trajectories? Do early decisions affect time to surgery and mobility? At the moment, we don't know because we're just not capturing it well enough. So for me, that's one big future thing. It's not there yet, but hopefully it's there. And then you can't go past the expansion of pre-hospital nerve block programs, I think. The evidence around them is rapidly growing and it's showing real positive effects. So I think it aligns perfectly with our, pre-hospital if we can get them there for those long transport times, especially in Australia. Like we're very rural, remote, and we have long transport times. So I think it'd be beautiful for us to see that, and I'm excited to see that develop more into the pre-hospital setting.
Yeah, and listen, I agree with you actually. And I think to your point, evidence-based medicine and indeed looking at the data and audits of the data, but fundamentally, as you were saying, collecting the data on these patients and exactly what's happening, time, and some metrics, time to surgical review, time to treatment, rehabilitation pathways, but understanding that collection of data builds the argument for, as you were saying, for these care bundles. Um, a tricky final question, but one would be really just forward looking
Mm.
into the future. In 10 years' time, if you could redesign a pre-hospital pathway for neck of femur fractures from scratch, what would it look like?
Yeah. I would love to see a streamlined, evidence-based assessment framework that just takes the variability out of the treatment of these conditions. Be great to see some decision supported tools that help flag frailty, delirium risk, comorbidities in real time. I'd love a structured, flexible pain pathway that's sort of consistent across the board and a greater emphasis on our non-pharmacological care. As it needs to be embedded as core practice. So taking that patient-centered approach. I think transport decisions would also be smarter. So I often find in my focus groups that they're sort of just going to the nearest hospital because we've got 1,000 jobs backed up. So I need to pick up my patient, I need to take them to hospital, I need to get to my next one. So they would probably be my main. And again, just to harp on it again, pre-hospital data finally to be valued. And we do this job to help patients. And it would be great to have some evidence showing that what we're doing is impacting. It is. I 100% think that what we do does matter, but it'd be nice to have that research and that data to sort of back that up and to strengthen that. In 10 years' time, if a patient can come and feel comfortable and safe the moment we arrive, I think we're doing something that's worthwhile.
Yeah, listen, that's fantastic, and actually, I fundamentally agree with that because there's a real service improvement need for the pathology around this patient cohort, and I think rooted in the data is a great baseline for improvement, but also measurement. To your point, Emma. Listen, thank you for the past half an hour. It's fantastic just to deep dive with you on this. We'll put links in the show notes to research that Emma's been focusing on and spoken to in the interview, just so you can go away and read more on the topic. Emma, it's been a pleasure. Thank you.
Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.